Good morning, everybody. Myself, Dr. Sudipto from Tata Medical Center, Calcutta. And in next 30 minutes or so, we will discuss about febrile patient with no neutrophil. I'd like to thank the organizers, especially Dr. Deepak, for giving me the opportunity to speak in this podium. So we'll start with a case. A 40-year-old gentleman with a diabetes and COPD on medical management and the comorbidities are partly controlled, develop acute myeloid leukemia and receive post-induction chemotherapy. On day 10, the patient will come to the ER with one episode of fever of 102 degrees Fahrenheit. CBC shows TLC total leukocyte count around 800 with only 1% neutrophil. So, what next? Are the findings significant? So, to know this, we have to go through certain terminology that first, when the fever is significant. So, a single oral temperature more than 101 degree Fahrenheit or a temperature more than 100.4 degree Fahrenheit sustained for more than 1 hour is called significant fever. The neutropenia is defined when the absolute neutrophil count is less than 1000 and in certain literature less than 1500 per cubic millimeter. It is called severe neutropenia when the absolute neutrophil count less than 500 or absolute neutrophil count is expected to decrease to 500 during the next 48 hours. If the absolute neutrophil count less than 100, it is called profound neutropenia, and if it persists more than 7 days, it is called prolonged neutropenia. Absolute neutrophil count can be calculated by multiplying the total WBC count by percentage of polymorphonuclear cells and band neutrophil. So, a manual reading of the blood smear is required to confirm the degree of neutropenia. Along with this, there may be functional neutropenia in hematological malignancy patients because of qualitative defect, that is, there is an impaired phagocytosis and killing ability for pathogen in certain neutrophil, in circulating neutrophil, and they are also considered to be at high risk for infection. In neutropenic fever, the incidence after chemotherapy is 10 to 50% in solid tumor and non-leukemic hematological malignancy, which is significantly higher in leukemic hematological malignancy, that is nearly 80 to 85% cases. In only 20 to 30% cases, we got clinically documented infection. And the common sites are intestinal tract, lung, and skin. In 10 to 25% cases, there are bacteremia. And most of this happened when there is a prolonged and profound neutropenia. Neutropenic fever syndrome, as per the International Immunocompromised Host Society, is classified into microbiologically documented infection when there is a clinical focus of infection and an associated pathogen. In clinically documented infection, there is a clinical focus like cellulitis or pneumonia without an isolation of an associated pathogen. And there may be unexplained fever when neither a clinical focus nor a pathogen could be identified. In most of this scenario, it is basically primary BSI when the bacteria or the fungus has transmigrated from the bowel because of loss of bowel mucosal integrity by the chemotherapy. So if you look at the clinical history, even the first episode of neutropenic fever is clinically significant, and we are supposed to start antibiotic to prevent poor outcome. A persistent neutropenic fever means that febrile episodes are continuing without defervescence for at least 5 days of initial empirical broad-spectrum antibiotic therapy in high-risk neutropenic patient and at least 2 days in low-risk neutropenic patient. If the fever recurs after initial defervescence, even when the patient is on broad-spectrum antibiotic therapy, it is called recrudescent neutropenic fever syndrome. And there is another terminology which is called myeloid reconstitution syndrome, which is because of fever and a new inflammatory focus or progression of a pre-existing inflammatory focus in temporal relationship to neutrophil recovery from aplasia. So whenever there is a neutrophil recovery, those activated neutrophil usually get mobilized to the site of infection and causing an organ damage. There may be systemic features like fever along with worsening of the organ function. If you look at the etiology, most of the cause of neutropenia is because of medications, in which chemotherapeutic drug is one of them, like in our patient. Along with that, there may be psychotropic drugs like clozapine, anticonvulsants like phenytoin and valproate, H2 blocker, antibiotics like penicillin or trimethoprim sulfamethoxazole, diuretics, thionamides, rheumatological agents like rituximab or sulfasalazine, non-steroidal anti-inflammatory drugs and allopurinol can also cause it. From infection, virus is the most common: HIV, influenza, hepatitis B, respiratory syncytial virus, or cytomegalovirus. They can cause bone marrow suppression and associated neutropenia. In bacteria, tuberculosis is one of the most common cause. There can be immunological cause or nutritional cause like vitamin B12 or folic acid deficiency. There may be hereditary causes like Cohen syndrome, cyclic neutropenia, or Costman syndrome, but which are a little uncommon in the adult patients and mostly present in the early ages. So if you look at the pathophysiology, there will be cytotoxic antineoplastic therapy, which is causing sufficient damage to the sufficient adverse effect to them for myelopoiesis and also causes loss in the developmental integrity of gastrointestinal mucosa. This leads to translocation of colonized bacteria and fungi across the intestinal mucosal surface, leading to primary BSI. And if the patient is getting glucocorticoid because of his primary therapy, it may mitigate the effect of fever due to bacteria or endogenous pathogen. So in neutropenia, you may have sepsis without any fever. Now, in terms of bacteria, it can be caused by both gram-positive and gram-negative bacteria. Among gram-positive bacteria, coagulose-negative staphylococcus, Staphylococcus aureus may be methicillin-resistant, Enterococcus may be vancomycin-resistant, virulent group of streptococci along with strep pneumoniae and strep pyrogens are the causative factor. Among the gram-negative pathogens, mostly the Enterobacteriaceae like Escherichia coli, Klebsiella, Enterobacter, maybe Pseudomonas, Acinetobacter, and Stenotrophomonas. Now, is our patient high risk? Why this term with differentiation in high risk and low risk is significant? Because this risk assessment will determine the type of empirical antibiotic therapy, that is whether IV or oral, the venue of treatment, whether the patient will be admitted, will receive inpatient therapy or outpatient therapy, and the duration of antibiotic therapy. So when you are talking about high risk patients, in that it is anticipated that neutropenia will be prolonged, that is more than 7 days, and profound, that is absolute neutrophil count is less than 100 because of the cytotoxic chemotherapy. Then there will be significant medical comorbid conditions like hemodynamic instability, oral or gastrointestinal mucositis, gastrointestinal symptoms like abdominal pain, nausea, vomiting, diarrhea, neurological or mental status alteration, which is new onset, intravascular catheter site infection, specifically for tunnel catheter because they are difficult to remove, new pulmonary infiltrate or hypoxia underlying because of or underlying chronic lung disease like COPD, or there is evidence of hepatic insufficiency or renal insufficiency. In all these scenarios, these patients need to be admitted to the hospital for empirical IV antibiotic therapy. And if the patient has an anticipated brief duration of neutropenic period like less than 7 days and there is no or few comorbidity, these are called low risk, and this patient may consider for oral empirical therapy on outpatient basis depending on many other factors that we will discuss later. Along with that, there are some scoring system which can objectify this risk categorization on neutropenia. One of them is called Multinational Association for Supportive Care in Cancer Risk Index, where it has included the burden of febrile neutropenia along with other symptoms, whether it's mild, moderate, whether in episodes of hypotension, any COPD, previous history of fungal infection, whether the patient is hypovolemic or dehydrated, and age of the patient. If the mask score is less than 21, that means they are high risk. They need to be admitted to the hospital for IV empirical antibiotic therapy. If the mask score is more than 21, they may be considered for oral therapy in an outpatient basis. And mask has a very good negative predictive value. There is another scoring system called Clinical Index of Stable Febrile Neutropenia, which include the ECOG score, stress-induced hyperglycemia, COPD, chronic cardiovascular disease, extension of the mucositis, that is how much the mucosa of the bowel is involved, and the value of the monocyte. And it has shown that when it compares with the mask or Talcott classification, which is an older classification, the area under the curve, that the sensitivity specificity is better in clinical index of stable febrile neutropenia to pick up complications for high risk patients. So if we come back to our case, so the patient come to the emergency, we have identified it as a high risk, absolute WBC neutrophil count is less than 500. So after the initial assessment, we have to take adequate history, we have to send cultures, we have to send some laboratory parameters and imaging, and have to go according to their reports. And at the same time, you have to start empirical antibiotic therapy. They need to be admitted, and it needs a multidisciplinary approach to address these patients. So these patients may need protective environment. If this is a post-transplant patient, probably he needs a high efficiency particulate air filter, that is HEPA filter, along with laminar flow. At least we can consider for a positive pressure room for these neutropenic patients. If nothing is available, we have to ensure that minimum number of air exchange should be available in the ICU where we are managing these patients. It should be at least more than 12. In terms of clinical assessment, we have to take detailed history along with detailed physical examination. During history taking, we have to elicit the new site-specific symptoms, information about previous antimicrobial therapy or antimicrobial prophylaxis, any history of infection exposure, prior documentation of infection or pathogen colonization, coexistence of non-infective causes like blood product administration which may present with a fever, or any underlying comorbidity like diabetes, COPD, or recent surgical procedure. For physical examination, it have to be a detailed assessment to pick up the subtle clinical signs. Sites that are most commonly infected are skin, maybe the central line or the PICC line site, insertion site or exit site. There may be infection at the bone marrow aspiration site. The oropharynx may be involved along with periodontum, alimentary tract, lung, and perineum. These are the parts which are mostly get covered, and if you don't do a detailed assessment, the source of sepsis may be missed. For investigation, routine blood count along with differential count and platelet, renal function and electrolytes need to be checked on admission and at least every third day, more frequent if the patient is critical, and with liver function at least every 7 days if it is stable. We need to send at least 2 sets of blood culture from each lumen of the existing central venous catheter or PICC line and one from the peripheral puncture. Total blood volume should be less than 1% of the total blood volume, which is more applicable for neonate and pediatric subgroup, not that important for adult. And other cultures need to be sent from other site of suspected infections, like patient may need to send sputum or bile, urine, stool, CSF or skin biopsy. Chest X-ray may be needed depending on the symptoms, and if the other laboratory tests are not helping, maybe we can use biomarkers like CRP and procalcitonin to identify sepsis on the progression of the course. Retrospective studies have shown that if you send 2 blood cultures, we can pick up to 80 to 90% cases of bloodstream related infection in critically ill patients. And if we increase it to more than 3, the sensitivity may increase up to 96% or more than 96%. So what about biomarkers? So if we can follow biomarkers, we know that single value of procalcitonin or CRP is not helpful, or interleukin 6 is not helpful. Single value cannot diagnose sepsis, but if you can follow them on a regular basis in neutropenic patients, if the values of procalcitonin and interleukin 6 is persistently high, that indicate a non-resolving sepsis and indicate a poor outcome. But usually CRP doesn't have this advantage. Again, if the procalcitonin value is not coming down after initial intervention or initial antibiotics, that means there is a clinical failure when patient may need to escalation of antibiotics. So in that scenario, probably more detailed investigation or to try to cover the odd bugs which may be missed in the initial cover are needed. There are other molecular tests which are PCR based tests which can identify the bacteria and with that help you can streamline your antibiotics because in neutropenic patients may get infected with very odd bugs, and covering every possible bacteria with your empirical antibiotic may not be feasible. So what will happen in this scenario, that with this PCR based test specifically from sterile site like blood, you can pick up the gram-negative bacteria like Enterobacteriaceae, gram-positive bacteria like Staphylococcus or Coagulus-negative staph, and also fungus can be picked out like Candida or Aspergillus. In terms of radiology, CT scan abdomen or chest may be very helpful because in certain time neutropenic enterocolitis may be the source of the infection or source of the fever. CT scan abdomen can identify it. There may be an invasive mold infection in the chest or maybe in the sinuses. CT scan chest and thorax and the sinuses may help us to diagnose it. So now what antibiotic? Our therapeutic antibiotic will depend on what is the antibiotic prophylaxis my patient is getting. No routine antibiotic prophylaxis is recommended for low-risk patients. For high-risk patients with expected duration of neutropenia is prolonged with a profound neutropenia, IDSA recommendation is for fluoroquinolones, that is either levofloxacin and ciprofloxacin. Levofloxacin is preferred because it also covered the viridin streptococci, which can cause infection in the background of oral mucositis. And addition of a gram-positive active agent with fluoroquinolones is not helpful. But there is a problem with giving prolonged fluoroquinolones prophylaxis because it increases the antibiotic resistance to the bacteria and fungal overgrowth. And there are recent multiple literatures and recommendations which are suggesting against fluoroquinolone prophylaxis even in high-risk patients like hematological malignancy who received hematopoietic stem cell transplant or even in case of prolonged neutropenia. In terms of fungal prophylaxis, prophylaxis needed for Candida, specifically for high-risk patients like allogenic hematopoietic stem cell transplant patients or those undergoing intensive remission induction or salvage induction chemotherapy for acute leukemia. You can use any azoles like fluconazole, itraconazole, voriconazole, or echinocandin like micafungin or caspofungin. But if there is an associated chance of aspergillus infections, like patients who are more than 13 years of age and also has received intense chemotherapy for AML or MDS, like our patients, then it is better to use posaconazole because which will also cover the aspergillus. Aspergillus cover is also needed in pre-engraftment allogenic and autologous transplant recipient patients, along with patients who have prior invasive aspergillosis, anticipated prolonged neutropenic period more than 2 weeks, or prolonged period of neutropenia immediately after bone marrow transplant. All these patients we have to cover both Candida and aspergillus. But in case of low risk patients, probably antifungal prophylaxis is not needed. Regarding antiviral prophylaxis, if the patient has an HSB seropositivity, so specifically in allogenic hematopoietic stem cell patients or leukemic induction therapy, after leukemia induction therapy, acyclovir prophylaxis is needed. But we give only therapeutic dose if there is evidence of clinical or laboratory evidence of viral infection. Respiratory viruses like influenza, parainfluenza, adeno, RSV, human metaneuro can cause new LRTI in and upper respiratory tract symptoms along with pneumonia. So maybe a PCR-based test along with chest X is needed if there is a clinical finding. Yearly influenza vaccination is recommended for these type of patients who are cancer patients who are receiving therapy. And optimum timing for this vaccination is between the chemotherapy cycle, that is more than 7 days after the last treatment or 2 weeks before the chemotherapy started. Influenza virus infection, if it is there, we need to treat it with a neuraminidase inhibitor. But routine treatment of RSV infection is not needed in every patient. It may be considered when the patient is severely immunocompromised or if there is a clinical deterioration. Now, if there is a clinical failure with your prophylactic antibiotic, then we have to consider for empirical antibiotic in this subgroup of patients. And selection of this antibiotic will depend on risk status of the patient, whether low risk or high risk, on localizing sign or symptom of infection like pulmonary cellulitis, because certain antibiotic will concentrate in certain organ. And we have to look at the trend in epidemiology of pathogens causing infection, along with the local and even individual patient pattern of bacterial colonization and resistance. So we have to know regarding in hospital antibiogram along with the patient's previous infection with different multi-drug resistant bugs. And the target is to cover most likely and most virulent pathogens as much as possible. So in high-risk patients, as per IDSA guideline, recommendation is to start with cefepime, carbapenem, or piperacillin tazobactam. You can add other antimicrobials like aminoglycoside, fluoroquinolones, and vancomycin. In my hospital, the protocol is to start with piperacillin tazobactam and fluoroquinolones in neutropenic fever without any organ dysfunction. Anaerobic gram-positive cocci is covered like a vancomycin or aticoplanin is given if there is a suspected catheter-related infection, skin or soft tissue infection, pneumonia, or hemodynamic instability. And if there is a patient's condition critical, patient deteriorating, there is complications like hypotension or pneumonia, or the patient has a positive blood culture which suspected or proven resistant bacteria, we need to expand the antibiotic spectrum to cover MRSA, VRE, ESBL, and CRE depending on the initial or preliminary report from the microbiology. And there may be risk factors like previous colonization or infection with this type of similar organisms. A patient may be in a hospital for longer durations, and when the chance of MDR infection is higher. Now, if the patient has an immediate type of hypersensitivity reaction with penicillin, then the choice of antibiotics will be ciprofloxacin, clindamycin, or aztreonam, along with vancomycin. Oral empirical therapy can be considered in low-risk patient when the patient is absolutely stable without any hemodynamic instability or organ dysfunction. Then the ciprofloxacin, amoxicillin clavulanic acid, fluoroquinolones like levofloxacin or cifro, or a combination with fluoroquinolones with clindamycin is an option. An outpatient treatment course can be considered after an oral or IV course in hospital if the patient has a brief inpatient stay and during which IV therapy was initiated, there is a fulminant infection which is excluded, the patient is deemed to be clinically stable at low risk of complication, assessment of family support has completed, that if the patient is deteriorated, they can bring the patient immediately to the hospital, and the status of initial culture specimen are ascertained. Now, regarding the combination therapy, studies then shown that if you combine beta-lactam along with aminoglycosides, though there is a less chance of treatment failure, there may be higher chance of mortality because of probably because of drug-related toxicity. And cefepime, whenever the study has a comparative study with cefepime with other beta-lactams, it shows that the clinical outcome or clinical failure is higher with cefepime compared to a beta-lactam. So, in my opinion, it is not a safe drug or a right choice, at least in Indian scenario. When to cover gram-positive covered, like a teicoplanin or vancomycin, we have already mentioned that in case of hemodynamic instability or patient with severe sepsis, pneumonia, documented radiologically, specifically if it is lobar, blood culture positive with gram-positive bacteria, even if the patient has a cons in blood, it is very difficult sometimes to ignore it in a neutropenic patient. We may send another blood culture and try to continue with the same antibiotic. If there is a clinically suspected serious catheter-related infection, skin or soft tissue infection, or colonization with methicillin-resistant Staph aureus or vancomycin-resistant enterococcus. So, if this is a tabular form given in IDSA, we have to first identify the patient with low risk and high risk, and we have to decide regarding the outpatient treatment or inpatient treatment. In low risk, if we decide about outpatient treatment, the choice will be ciprofloxacin and amoxicillin. Or if the patient is sick, then probably, as I discussed, it may be piperacillin tazobactam or carbapenem. Now, when to escalate antibiotic? With empirical antibiotic, if the fever persists for more than 5 days in case of high-risk patients and more 2 days in low-risk patients, we may consider to escalate the antibiotic. But if there is a persistent fever but no other organ dysfunction and patient is stable, maybe the routine observation is helpful. If there is an organ dysfunction, probably if you have to start either carbapenem, if it is not already there, along with polymyxin, tigecycline, fosmycin, and we need to send repeat culture after detailed assessment of the patient to pick up the appropriate source. Empirical vancomycin is still not needed, at least in present scenario. Gram-positive cover need to be given, as I mentioned, if there is a positive blood culture related to central line related infection or there is a skin soft tissue infection. What about the duration of antibiotic? You have to continue this broad spectrum antibiotic till the patient is febrile for 48 hours, or along with that, there is a recovery of marrow with a absolute neutrophil count more than 500. High-risk patients who have a persistent or recurrent fever more than 5 to 7 days, who have received broad-spectrum antibiotic therapy, still not improving and the neutropenia is prolonging, then we have to consider for empirical therapy, which covers the mold. In that situation, we have the patient not responding to the antibiotic along with the antifungal which covers the mold. We have to do detailed assessment, like maybe we need a CT scan or MRI to identify the source, or the, for a deep-seated infection in lung it may be a mold, in case of abdomen it may be a disseminated candida infection. So the source need to be identified and we need to do detailed assessment. Regarding antifungal, it can be empiric or preemptive. Empirical antifungal therapy, as I discussed, need to have to be started if there is a persistent fever, even after 5 to 7 days of antibiotic therapy. If the patient is receiving some antifungals already, then you have to switch the classes to cover the antimold. And preemptive antifungal therapy is also an alternate acceptable option where we are guiding or restarting the antifungal or modifying the antifungal therapy depending on some radiological or biomarkers. So those who remain febrile for 4 to 7 days of broad spectrum antibiotics, but clinically stable, no clinical or no clinical finding, chest or sinus CT shows no fungal element, negative serology for all the fungal parameters, and we could not recover fungus from any other sources, we may consider to hold the antifungal. And in low risk patients, the risk of invasive fungal infection is low, so routine use of empirical antifungal is not recommended unless we have a definite source. So in case of failing antifungal prophylaxis, along with modification of the drugs to a different group along with a mold cover, we need to consider the source of the infection. So detailed assessment in terms of microbiology and also radiology is important. Indirect tests like galactomannan in serum and bronchoalveolar lavage for aspergillus, or mannan and beta-glucan for candida, along with real-time PCR of aspergillus and candida may help to start preemptive antifungal in this subgroup of patients. And if the patient is on oral azoles, then serum level of the prophylactic drug need to be checked. There may be a clinical failure because of subtherapeutic level of the drug. Because of posaconazole, itraconazole, or voriconazole, the oral absorption can be little dodgy. Whenever we are reading these values, we need to interpret with caution, because in lot of scenario, the these biomarkers can give a false result, false negative or false positive. Like in case of galactomannan, use of antibiotics, pediatric or neonatal patients, infection caused by penicillin species, and dialysis, all this can give you a false positive results along with plasma life solution. CT imaging, CT may show a nodular consolidated ablation with widespread infarct. Halo sign will indicate a nodules more than 1 centimeter surrounded by perimeter of ground glassing opacity. There may be pleural effusion, and when the fungal infection, aspergillus infection resolving, you may find a air crescent sign. For a more invasive moles like mucor, you may need an MRI to look at the osseous involvement, paranasal sinus involvement, and CNS involvement. So this is a CT scan showing nodular shadow at the pleural base along with halo. And this indicates a air crescent sign suggesting of fungal infection, mostly aspergillus, which is resolving. So if there is a persistent fever, one issue is we have to look for the raising ANC, whether there is a myeloid recovery is imminent or not. If it is there, then it's a myeloid reconstitution syndrome. We need to monitor those function, and if there is a deterioration in the organ function, we need to support it. If the myeloid recovery is not imminent, then you have to look for what is the prophylaxis the patient is getting. If patient is getting fluconazole prophylaxis, we have to broaden it to mold cover. If the patient is receiving an anti-mold prophylaxis, probably we have to add a different subgroup of antifungals. Like if the patient is on voriconazole, probably I will like to add an amphotericin. Adjuvants, we can use GCSF to decrease the duration of neutropenia. And if the chance of neutropenic fever is more than 20%, along with their multiple comorbidities like age more than 65, previous episodes of neutropenic fever, advanced age, serious comorbidities, poor nutritional status, patient receive combined chemotherapy, we can consider for a GCSF. It is not recommended if the chances is less than 10%. And it is not recommended once there is a fever and neutropenia. In case of therapeutic option, it is not recommended. Regarding intravenous immunoglobulin, it is not recommended in routine basis, but if the patient has a persistent low level of IgG and there's a non-resolving sepsis, we can consider in a case-to-case basis. Regarding granulocyte transfusion factors, the data is very limited, and we can in 10 RCTs, the Cochrane review, which has included 10 RCT with no mortality, shows no mortality benefit. But if you look at the cell dose, that is the cell dose is more than 1 into 10 to the power 10, there with a prophylactic intent, that is the prophylactic granulocyte transfusion, there is an improvement in the mortality from infection. So again, it have to be used in a case-to-case basis. In terms of other supports, it is neutropenic sepsis is reasonably same like any other septic patients. In terms of respiratory supports, that we know that because of the immunocompromised status, we try to avoid invasive ventilation, we try to manage with NIV, and presently more with an HFNC, specifically after our experience with COVID. So, but whenever we are managing them with NIV, we need to look at the risk factors of NIV failure. There may be some risk factors are there even prior to NIV, like vasopressors need, multiple organ failure, airway involvement by malignancy. Along with during NIV, patient may not be tolerating it well. There is no improvement in ABG, persistent tachypnea, patient is requiring continuous NIV. Even with minimum removal, patient is desaturating. In this situation, probably invasive ventilation is needed. And with my experience, I can say a lot of immunocompromised patients, neutrophil very low, go into ventilator, may require, because of ARDS, may require prolonged ventilation, prone ventilation, they come out successfully. So it's not like that if a neutropenic patient go into ventilator, they does not come out. So to conclude, managing a neutropenic fever and neutropenic sepsis is very challenging because they are very immunocompromised. Detailed regular clinical assessment is needed to identify the source of infection because there may not be any fever, and because of neutropenia, we may not be able to identify the source. In that situation, and PUCAS can really help us to identify the source of infection. When you are managing sepsis, suspect every bug. Any bacteria can cause this infection because they are so immunocompromised. Prolonged neutropenia is a big challenge because you have to maintain a stringent infection control protocol in your hospital, in your ICU to manage this patient to prevent hospital-acquired infection. There may be associated cytopenias, mostly thrombocytopenia, which prevent from different invasive procedures in case of non-resolving sepsis, like it is difficult to do a BAL if the platelet is persistently low, or difficult to do a deep-seated biopsy from the liver or spleen if the patient has less than 10,000, 15,000 platelet. Yes, this patient has a higher mortality compared to any other ICU, but still there's a significant number of patients could be salvaged, and we need to have patience and perseverance and have to continue good clinical practice, good critical care, good organ support to take this patient out of this crisis. By this, I like to conclude my presentation. Thank you.